Randy D'Amico has just joined us as well, and we're honored today to have the group from Allegheny Health Network describe their recently published work on stereotactic radiosurgery for recurrent high-grade gliomas, a systematic review. This is a topic that's near and dear to many of our hearts, so we look forward to hearing the work. And then we'll have the opportunity for participants that are with us in real time to enter some questions into the chat function, and we'll try to get to everything we can in the course of the next 30 minutes. So with that, Dr. Shepard, if you want to take it away.
Yeah, thank you, Chris, for allowing, giving me the opportunity to talk with everyone here with the Journal of Neuro-Oncology and the Seattle Science Foundation. It's really a great honor to be here with my partners Rodney, Wegner, and Trent Kite, who did most of the work on this study. So, even though really the topic of the paper, that we published recently is on radiosurgery for recurrent high-grade gliomas, I think what we're hoping to maybe achieve a little bit today is just to have like a little bit more of a discourse about what's the best way we manage patients with recurrent glioblastoma in general, because this is a very heterogeneous disease at initial diagnosis, and certainly in the recurrent setting especially so as well. And just to kind of give this a little bit of the context, I mean, so this is oftentimes for those of us who specialize in neurosurgical oncology, I mean, this is not an uncommon thing that we see. This was a 49-year-old gentleman with a history of recurrent IDH-DBM, unmethylated, 2 years after undergoing a successful left temporal lobectomy, now comes to our office in our clinic and with a recurrence in, kind of infield recurrence. And then the question becomes really, now what do we do? And I think, when we put this in the context of, again, in the early 90s, there were many papers that were publishing, data on, really even kind of begging the question of whether or not we should be offering resection initially for these patients with the glioblastoma. We now are kind of very privileged to have high-level data from the Wegner Resect group and others, saying in the recurrent setting, almost irrespective of MGMT methylation status, re-resection for cytoreduction in this recurrent setting does confer a significant survival advantage, assuming you can get down to less than 1 cc of residual tumor. And so, for this patient, I mean, obviously someone who's young, I mean, this is a patient who we, at least in our practice, wouldn't typically consider for radiosurgery. And as such, we did, a surgical excision on him. But in this, day where we're having more and more treatment options available, including even some centers using brachytherapy for the recurrent setting, I think trying to define, at least from the neurosurgical oncology standpoint, what's the best treatment algorithm for these patients is going to be on more and more imperative. Likewise, we have other options that are not, re-resection based, like LIT, for example. This was a patient of mine, young woman who had a motor strip molecular glioblastoma, GBM. And, 1 year after open biopsy and adjuvant treatment, she went on to present back with significant hemiparesis. This is a case where I think tissue diagnosis was exceedingly important. And so we, again, this is a patient we did LIT on. And I think that, this is, again, a minimally invasive option for patients. And again, from the recurrent setting, has shown some efficacy. But then there's patients like this who come back, who's a little bit an older gentleman who had a right temporal glioblastoma resected by one of my partners several years earlier. Now, 2 years later, coming back in with really kind of deep-seated, disease, at least in my opinion, is not really a great surgical target. And, while some centers may consider LIT in this case, this was a patient to me who I would, be more considering, radiosurgery. And as, Chris, as we were alluding in the conversation, I mean, this is a diffuse disease. And so I think there really does beg a question in a patient like this, what is the optimal treatment, strategy, knowing that for many of these, patients, the disease that we're seeing on the scan, obviously, is just the tip of the iceberg, and there's going to be significant non-enhancing disease elsewhere. And so, is there a benefit of obtaining kind of more aggressive local control with radiosurgery? And this is really, I think, kind of was the pretext for us kind of looking at doing more of a systematic review in this topic. Conferring from some of the literature from, some other centers looking at systemic treatments for recurrent glioblastoma, what we can see is that there is a trend, at least with obtaining objective response rates, with systemic treatment, that those patients do better longer term. So that, coupled with the Wegner Resect data, does give us some indication that maybe being more aggressive with these enhancing disease in patients who are older and not great surgical candidates or surgical targets may be beneficial. And up until now, we've really had a spattering of, well-designed, retrospective papers that have examined the topic of radiosurgery in the higher grade, glioma literature. But still, I think this is not necessarily something that you see every single day. And so I think it does kind of, warrant, further investigation. Last year, Trent, who worked with me for the last year and with Dr. Wegner as well, kind of really took this project on, and I'll let kind of Trent kind of go over our results at this time.
Yeah, so as Dr. Shepard mentioned, prior to this article that we put together, there really wasn't a good systematic review on this topic. There were a couple recently published retrospective reviews that came after a previous systematic review, but up until this time, there wasn't kind of a what I would say is a good lay of the land. So that was kind of our motivation in doing this article and writing this paper. And we pretty much kept our search criteria very broad. We searched the PubMed databases, the ScienceDirect databases, and used pretty broad search criteria. We looked for glioblastoma, high-grade gliomas, anaplastic astrocytomas, SRS, Gamma Knife, CyberKnife, LINAC-based systems. Right? We pretty much just kept this a very broad search. Ended up getting about initially 2,145 articles. We got that down to 22 articles for review. These articles span 1999 all the way up till one of our recently published papers in 2024. So we had about 2 decades worth of data included in our systematic review. Most of these were, unsurprisingly, WHO grade 4s. There was about a quarter of them were grade 3s. Median volume was 9.9 cc's, and approximately half employed fractionation schemes. These typically were articles that were published beyond 2010. So ultimately, what we looked at was 1-year overall survival, 12-month local progression, and distant progression, kind of the standard run-of-the-mill primary and secondary outcomes for any SRS paper written in the previous decades. So at 1 year, overall survival was 53%. This was an actuarial rate that was pooled across all studies that included sufficient data for which we could collect. 12-month local progression was 58%, and 12-month distant progression was 35%. Grade 3 toxicity was wide-ranging. However, no study reported greater than 14% of participants experiencing grade 3 toxicity. This is one of our first tables in the paper. You go back there real quick. And one of the things to highlight here, honestly, is the fact that one of the biggest issues with the data to date is just the heterogeneity, particularly if you look at the chemotherapy regimens that the patients that we included were on. A lot of the articles didn't necessarily really even report the chemoradiation regimens that these patients were on. A lot of the data, given that it spans from 1999 all the way to 2025, a lot of the articles were actually in the pre-Stoop protocol era, which again is another limitation of this type of analysis. So one of the good things I think that we included in this article is really we kind of tried our best to delineate what the regimens were, and it kind of is an alphabet soup if you look at it. But I think just visually looking at this table shows you how heterogeneous the data actually was. And then, if we look at some of our other data here, one of the big things that is a point of contention in this field is that, or at least in this topic, is the fact that some of the intervals from the index procedure until the time of recurrence or stereotactic radiosurgery for recurrence were wide ranging. And this kind of speaks to a potential selection bias in that, the patients who are recurring very quickly potentially have underlying histologies and disadvantageous biology. And that could be driving some of the results we see with patients who are treated in the recurrent setting with SRS. And so many of the studies were confounded by the fact that they either selected for those types of patients, or they had the alternative problem where they had patients that were living for exceedingly rare or exceedingly long periods of time. So capturing that in-between data and trying to tease out that confounding effect is going to be an important step in making our data more robust in the future.
Yeah, so I think just to, and again, so kind of going back to this kind of patient again, what we got with him was 25. We are a little bit more heavily biased, I think, towards like fractionation, at least at AHN, and at least for these patients who are kind of more heavily treated in the past with radiation. So in this case, we did treat this patient over 5 fractions, 25 gray over 5 times 5. And at 6 months, later, he did have a reasonable amount of local control, but obviously as we discussed earlier, he had disease progression kind of more distally, and eventually is still undergoing treatment at this time. But I mean, I think I think this paper is with anything else, right? I mean, this is all it's an amalgamation of a lot of many retrospective series with significant case selection biases, and I think there's still many questions that remain, and I don't certainly think that this one paper can answer all of them or address them, but I think like with any thing in neurosurgery and neurosurgical oncology, I mean, the more questions we ask, the better. And again, I think going back to the kind of our little bit of an intro, I mean, I think the question really is kind of what are the best patients for surgery? Where does lit fit in with all that? What about radiosurgery? And if it is radiosurgery, single fraction, multifractionation, or is there a combination of strategies with systemic treatment? And where does SRS fit in with that? And is there an optimal size for SRS? When does a lesion become too big or too small to really warrant radiosurgery? So we certainly don't pretend to have the answers to really any of these questions at this time. But I mean, I think it's an important talking point at this point in the literature.
Well, thank you. Dr. Wegner, do you have anything you want to add to the presentation so far?
I think, Matt and Trent did a great job summarizing current data and paper that they put together. Just like to highlight, fractionation as an option. If you look at what the median size was in that meta-analysis was 10 cc's, which is rather sizable. So having a machine like the Gamma Knife Icon or a LINAC-based approach allows us to safely deliver, hopefully, an effective dose with less toxicity, at least anecdotally, I would say.
Yeah, I think we'll get to some questions from the participants in the webinar. If you have some, please, I remind you all to type them into the chat function, and we'll try to answer all of them. But I'll start out, Matt and Rodney and Trent. You touched on the fact that obviously there's a lot of heterogeneity in our historical data on glioblastoma. We can't even agree for more than 5 or 6 years what is a high-grade glioma. We come out with a new test, and I think if you tried to parse through most of those papers, you'd find that the data is just not there to be able to say if this would meet current criteria for glioblastoma, IDH wild type, grade 4 tumor. So obviously, if you're treating disease that's recurrent disease versus multifocal disease at presentation, I think that's one major factor that needs to be considered. And how strong of a factor do you think the timing was in this process? Meaning disease that's 6 months out versus a year out versus 2 years out. How much do you think is kind of hidden non-contrast enhancing tumor that then progresses into contrast enhancing tumor, and let's say IDH mutated subsets? Just to make a random guess out there. What do you think? What's your feeling?
Well, I mean, I think the molecular, I think one of the things lacking for many of the studies included was a detailed understanding of what the actual molecular diagnostics were in many of these patients. And so, and I think to your point, I mean, certainly what's been the trend, and at least in many recurrent, GBM studies, is that typically the longer time to treatment, the longer duration, and generally, speaking, that's associated with improved outcomes. It's not universally, though, in all these papers that have been published. Our own series, did kind of, that's been our experience, is that the patients who've done better longer typically probably have a less, aggressive, disease. And also then you can potentially even have other, treatment options. If you fail through temozolomide, well, then that's the first, chemotherapy agent. And sometimes people doing re-challenges with Temodar is effective in that setting. So you have more options, I think, the longer people go, and also you probably have a little bit better safety profile with the longer interval between, prior external beam radiation therapy and SRS.
Yeah, Jason, did you want to add anything on there? I think our IRF papers kind of touch on that as well. That the further out you were, the more likely it was to have better local progression-free survival time.
No, I think you're correct, and that there is a project that's underway through the IRF too that would potentially link some of the rano research with the IRF data. And I think, it's very difficult to do these studies prospectively, but to be able to collect data that's part of multi-center cooperative groups, we may actually be able to look at the value proposition of repeat resection versus repeat radiation in the form of radiosurgery, or even a combination of the two. But the permutations are considerable, especially when you start thinking about the molecular subclassifications within gliomas, and what they may have seen before, what molecular status they may have, and where they may have developed some resistance to past treatments. But I wonder, in your review, what kinds, if any, of the advanced imaging modalities do you think were being used in some of these series, Trent? Was anyone using more metabolic imaging, spectroscopy, and where do you see this field evolving, perhaps Rodney or Matt, in terms of that tip of the iceberg versus identifying the whole iceberg when you're thinking about using lead or radiosurgery, or for that matter, even cytoreductive resection? What could you glean from the literature that you turned up, and where do you think that field's going to go? How much more advanced imaging are we going to use? As an aside, there was a concept that was sort of put forth, this leading edge concept in radiosurgery years and years ago, and it did gain a little bit of traction, had some positive signal on a few very selected patient cohorts. But there they were using some advanced imaging, including diffusion, perfusion, and even PET, and they're targeting for radiosurgery. And they combined that at one point in a trial, which unfortunately we were not able to participate in, that did use lit. So, but I'm interested to know what you found in the literature, and what your expert opinions might say in terms of forecasting the future.
Yeah, I'll take the first part. To my knowledge, I don't believe anyone beyond perfusion imaging was using anything like PET or MRS. So, and I think that's a really good point. And I may have made a point about this in the discussion about how, identifying recurrent disease on MRI and standard MRI sequences in today's day and age may be limited, right? And I think that incorporating that into future studies is only going to increase our ability to identify disease and more accurately predict what we're actually treating. And I think that that's definitely an area of opportunity in this space. And I think future studies definitely should incorporate that.
Yeah, no, I mean, I agree with Trent there. I mean, Rodney, I mean, I can talk of a few ideas for the future, but do you have any other thoughts? I mean, from your standpoint?
Not necessarily. I mean, I've heard of some single institutions doing almost like a SIB or a simultaneous integrated boost to try to cover more of the non-enhancing tumor using either gamma knife with fancy planning or just traditional IMRT techniques. But to my knowledge, I think the outcomes are still at this point similar.
I feel like the volumes get so big too. I mean, you start running into problems with the limitations. Matt, Rodney, Trent, I really appreciate your guys' time today. The reason I really reached out about this article in particular is that I think this is something that we all do, right? We all use radiosurgery at some point in these patients, and based on the overall survival, 50% getting another year. And I believe that was from the point of radiosurgery, correct? If I'm not wrong there. Which is a pretty significant number. What I like about it is that this is not relegated to your molecular profile. Radiation treats and works on all GBMs. And so what you guys have done with this review is shown that we're not crazy for doing this. It's still a very viable option. And it allows us to still be aggressive, in places where we couldn't be aggressive and add to our armamentarium. Now, that was my big reason for inviting you guys on, because I think this is an important topic to cover. We have a question from the Q&A and a similar question in the comments that I think are both related to that. So in the Q&A, people asked about immunotherapy, and in the comments, people asked about an abscopal effect. And now, while GBM doesn't, metastasize like we would consider abscopal effect in metastatic disease, this concept of priming the immune system, the use of immunotherapy, whether it's radiosurgery or laser ablation, do you guys want to comment on that at all for the kind of the future of this care?
I mean, I think it's a natural, next logical question, right? I mean, I think with, but to be frank, I mean, I think, we're kind of, at least in the metastatic realm, I mean, I know when I was at UBA, with Dr. Sheehan as a mentor, we looked at this, specifically with some metastatic disease. And I think the kind of our data did not really show a significant intracranial abscopal effect. And so to say it's going to now be there in GBM, I think it's worth investigating and looking at. Is it going to be the for sure thing? I can't, I don't know. I mean, I think it's a good, but it is a reasonable thought. I mean, but I don't know, Dr. Sheehan, Dr. Cifarelli. I mean, if you guys have any other thoughts on that, it'd be interesting. So it's a good question.
I think some of this really comes down to the fact that we don't have a real good understanding still of how much is progression of disease that's non-contrast enhancing, and we can't really predict where it's going to pop up, and what our first pass of treatment's going to be with normal external beam techniques. Are we really frying the whole field and making sure that what's coming back is new, or is this just partially treated disease? And, when you talk about abscopal, at least in the setting of GBM, I don't think it's that far off topic, because I think there is some element of immune capacity to be able to try to suppress disease, especially in newer trials. They're looking at immune agents, and radiation, we know, is a great antigen presenter. If you're going to lyse cells and dump them into the field, you could certainly create a phenomenon by which you have off-target effect, which is really what you're talking about. To that end, what do you guys think of the role? And when I treat patients like this, I almost invariably will have some sort of preceding course of bevacizumab, because I'm always deathly afraid of causing a malignant inflammatory response. And I also want to try to create a target that's not so diffuse as if I'm going to try to treat it in single fraction. So, the Cleveland study had looked at pre-treatment 7 to 10 days in advance with a dose of bevacizumab. What's your practice in treating these patients?
Yeah, I mean, I know that paper. I mean, I know the data you're alluding to. I mean, and I think it does, show, it makes sense. I mean, especially with the radiation standpoint. I mean, oftentimes bevacizumab is something that we do employ in conjunction with our neuro-oncologists, and I think honestly, when every single one of these patients that we treat, we actually, me, Rodney and our neuro-oncologist, we all sit down together and we see them the same day, and so oftentimes we're employing that if they're otherwise candidates for it, and if it's going to make sense in their other systemic regimen. It's not 100%. So I don't think we're dogmatic from that standpoint, but probably, I'd say at least over 50% are going to receive it in and around the time, but we're not so strict on the time frame. And quite frankly, I don't think we're there to the point where we're saying, hey, like, you have to do it that way. But I mean, I think it makes, complete sense.
Randy, yeah, just to weigh in, we don't routinely give it. We're not very protocolized about that. I think we try to save Bev for the last resort. I think I'm not familiar with that paper, and it's interesting because I know that radiation works better with oxygen, and with Bev, you're normalizing these blood vessels. I have to do my homework on it a little bit and see, what the potential benefits will be there. But listen, Matt, I have to jump into a case. I wanted to thank you just personally for coming on board, and the rest of the team for your contribution. And thank you, Jason and Chris, in advance for closing this out today. But great session. I really enjoyed it.
Good luck with your case, Randy, and thank you, Matt. And I did want to, and Chris, and Rodney and Trent, I did want to put in a mention that some of the IRF papers, including ones that relate to radiosurgery for glioblastoma, did suggest, as Randy had indicated, that even patients with that there was a comparable response with or without IDH1 mutant. So irrespective of IDH1 mutant status, you could still see a value proposition to using radiosurgery in selected patients, suggesting that, as Randy had indicated, that in fact radiation doesn't necessarily have to be as it's problematic when these tumors either have poor molecular status or maybe have developed a bit more resistance. That resistance is not necessarily dramatically changed for high dose per fraction radiation. So, but look, this is fantastic. I appreciate you all joining. I want to put in just an outstanding commendation to Trent, who's helped so much with a lot of JNO, and I'm impressed by what all he's been able to get accomplished, including this paper that he's taken such an important role in, working with Dr. Shepard and Dr. Wegner to bring this forward to JNO. So thanks so much. I think we'll probably try to conclude this session, as Randy would say. We'll try to keep this brief, and I think we're coming in at that 30-minute time point. So thanks so much for joining, and with that, we'll conclude this tumor talk.
All right. Thanks for having us on.
Thank you.